guys, we're going to talk about chapter 39, and this is going to talk about nursing care of the child with an alteration in sensory perception. And we're going to look a lot at the disorders of both those eyes and the ears. So let's get started here. The anatomy of children's eyes and ears differ somewhat from adults. Eye color is typically determined by 6 to 12 months of age. A newborn's lens can only accommodate about 8 to 10 inches. Visual acuity develops from birth through early childhood. You're usually going to see that 20/20 visual acuity by about the age of 5. Binocular vision, which is that ability to focus with both eyes, is achieved by 3 to 7 months. As you can see in the photo, the infant's eyeball occupies a very large space within the orbit than that of the adult. So this makes that infant more susceptible to injury. When we look at the variations in ears, hearing is intact at birth. Infants can hear just like an adult as soon as they come out. The eustachian tubes are short and wide and horizontally placed. And this just allows for more bacteria and viruses to gain access to that middle ear easier. And some children can have recurrent ear infections that could lead to some type of hearing impairment. So you can see in that picture below that adult ear and then that child's ear, and you can see how much shorter and horizontal that eustachian tube is with that child's ear placement. So before we start any labs or diagnostics, we need to inspect and observe, and this is the start of our physical assessment. So when we start observing for eye disorders, the first thing we want to note is are they wearing any eyeglasses? Do they have any corrective lenses? This could really give us a good idea if diagnoses have already been made or determined. We want to assess the positioning and the symmetry. Check for any presence of strabismus, which is that inability to align both of their eyes, usually called cross-eye. We want to look for any presence of nystagmus, which is that repetitive, uncontrolled movement of the eye, and if we note any squinting. We want to assess the eyelids and if they open equally. Failure of ability to open each eye equally is called ptosis. We want to note any variation in eye slant and the presence of any epicanthal folds, and then assess that eye for any edema, sclerocolor, discharge tearing, pupillary equality, and size and shape of pupils. As we observe the ears, we inspect the ears, and we're going to note the size, the shape, the position, any presence of any skin tags, dimples, or other anomalies. When we think about our otoscope examination, this is typically done by an advanced practitioner, but if you have the chance to peek in a cooperative child's ear and you want to, you can note the presence of cerumen, which is that earwax, discharge, inflammation, or any foreign bodies in that ear canal. When we visualize that tympanic membrane, we're looking for that color. It's usually kind of that gray, opaque color. We're looking at landmarks, light reflex, the presence of any perforation, scars, bulging, or retraction. So the next part of our assessment piece is that visual acuity testing, making sure that's age appropriate. We're using the Snellen chart if they know their alphabet, the tumbling E for our younger population. We may do some audiometry and tympanometry. Audiometry is that hearing test. I'm sure you all have been able to experience that in your elementary school days. Tympanometry is used to detect problems in that middle ear. So this is a device that they place in the ear, and it changes the air pressure in that ear and makes the eardrum move back and forth. And this helps determine the extent of any effusion of that middle ear and just how much fluid may be present. Inspection of tympanic membrane with an otoscope. Again, that's done by that advanced provider. And then tympanic fluid culture. And this is, you can take a culture of the eyes or the ear drainage, and this can help determine any specific bacteria that may be growing and the appropriate antibiotic coverage. Collection of this discharge for the lab is a nurse's task. Reading the culture result is that provider task. Remember, we do want to use our atraumatic care when we're collecting those lab specimens, as that patient may have some pain associated with either that eye or that ear discomfort. When we look at the physical testing of the eyes, we are looking for any abnormal extraocular movements. Is there any nystagmus or involuntary movement of the eye, or is there any strabismus, which is that cross-eyed appearance? Pupillary light response and accommodation we know is PERLA. Are the pupils equal? Are they round and reactive to light? Do they accommodate? So picture 1 there shows shines that light in the eye, and you can see that pupil constrict and accommodate for that brighter light. More advanced practice nurses or physicians will check for corneal light reflex and red reflex. They are checking for symmetry of that corneal light reflex. The top child is looking for that symmetrical reflection of light. And you can see the white pinpoint reflex is symmetrical. The bottom black and white photo shows a child with strabismus, and that reflects the light unevenly. When we assess red reflex, light shines in the eye and a red reflection will be seen by the ophthalmoscope. If there's not a red reflex or white pupil or a white pupil, that could indicate cataracts or retinal detachment. Testing of ears that's performed during our physical examination can include audiometry, which we've already kind of talked about. It's that range and sensitivity of hearing. Tympanometry, we've also talked about, checks for that movement of that eardrum and determines the extent of any effusion in that middle ear. The whisper test is just as it sounds. The examiner will whisper a series of numbers and letters into the patient's ear upon exhalation, and if the patient is able to repeat it, then hearing is intact. Weber and Rhine tests are for conductive or sensorineural hearing loss. And then culture of that tympanic discharge, we've also discussed obtaining that fluid drainage to test for any specific bacteria or treatment. So these common medical treatments can be found in your book on page 1382. For the eyes, we can think about a warm compress. Usually we're going to use this for conjunctivitis to help pull some of that goopy stuff out of the eyes. Just be conscientious about the temperature of the compress. Corrective lenses, which could be eyeglasses or contact lenses. Patching can also be a treatment, and that's applying the patch to the healthy eye to strengthen the weaker eye. And then eye muscle surgery is just that surgical alignment of the eye, and that's usually done with strabismus that can't be corrected without patching. For the ears, our treatments are those pressure equalizing or PE tubes, and they're the tiny plastic tubes that are inserted in the tympanic membrane to help relieve effusion from chronic otitis media. Hearing aids, amplifying devices worn in the ear for hearing impairment, and then cochlear implants are those surgically inserted electronic prosthetics devices for sensorineural hearing loss. So some common medications that are used with eyes and ear disorders are included here: antibiotics, antihistamines, and analgesics. And you can see those actions, indications, and some of the nursing implications there. There are several factors that increase individuals' risks for developing visual impairment: prematurity, maybe some developmental delay, a genetic syndrome. If your family has history of eye disease, that can play a role as a factor. African American heritage have an increased risk. Previous serious eye injuries, diabetes, HIV, and chronic corticosteroid use can all be factors that will increase the risk for developing any impairment visually. So some of the infectious and inflammatory disorders that we're going to look at are conjunctivitis, nasolacrimal duct obstruction, eyelid lesions, and periorbital cellulitis. Conjunctivitis, also known as pink eye. This inflammation can be viral, bacterial, or allergic in nature. Therapeutic management of conjunctivitis includes antibiotic use for those bacterial infections. We'll just do supportive care for our viral infections, and we may use an antihistamine drop for our allergic response. Conjunctivitis is highly contagious. Most patients will present with redness, edema, and discharge. Nurses can help patients by alleviating those symptoms by keeping that eye clean with a cool, moist cloth, wiping from the inner canthus down and away from the other eye to prevent that spreading of that infection, remembering that is highly contagious. We really want to educate our parents that the child has to be out of school until there's no drainage noted, which usually takes about 24 hours after they've started the antibiotic. Nasolacrimal duct obstruction is a common disorder of infancy. It does occur in about 6 to 20% of infants. Stenosis or simple obstruction of that duct usually resolves by about 1 year of age, and it usually is unilateral in 65% of the cases. I don't know that I've ever seen this in both eyes. It always typically sticks to just one eye or the other. Tearing or discharge from one or both eyes usually begins around 2 weeks of age. Redness of the lower lid of affected eye can be present. We can do cultures of that drainage to rule out conjunctivitis. Nursing management is going to include education for those families, teaching them to massage that duct and cleaning the eye area frequently with a moist cloth. Some of the eyelid disorders that we're going to talk about are hordeolum, which is just a stye. It's also known as a stye. Is that localized infection of a sebaceous gland of that eyelid follicle. Antibiotic ointment is usually used as a treatment for those styes. Chalazion is a chronic painless infection of the meibomian gland, and it will typically resolve spontaneously. And then blepharitis refers to just a chronic scaling and discharge along that eyelid margin. Usually these patients are going to need antibiotic ointments as a treatment. When we look at periorbital cellulitis, this is a bacterial infection of the eyelid and sometimes the surrounding tissue of the eye. Staph aureus and strep are the most common bacteria that we see with this. Therapeutic management is going to focus on IV antibiotic administration acutely, followed by completion of that course orally. As far as nursing management, we're going to apply warm compresses to the eye for about 20 minutes every 2 to 4 hours. We're going to administer that IV antibiotic, and we're going to educate that family to take all of that medications once they go home on those orals. We will want them to return for evaluation if it's not improving, making sure they have the ability to report if there's no movement in the eye or if visual changes occur, then they need to be seen again. If periorbital cellulitis progresses to that orbital cellulitis, this is a more extensive infection that involves that orbit of the eye. And again, just staying on top of that so that it doesn't get to that point. Eye injuries of infants and young children are more susceptible because remember that it holds a larger area in that socket. Those eyeballs are large in relation to that space. Types of injuries that require referral to an ophthalmologist include those that are listed there for you. Traumatic hyphema meaning that blood collection in the front of the eye, a blowout fracture, ruptured globe, thermal injury, if there's an extensive animal bite where the eye may be infected, lid laceration, corneal abrasions if the cornea is penetrated, or if there's any foreign body that's embedded in the globe. Those would all be injuries that an ophthalmologist should be following up with. Non-emergent eye injuries, you can use cold packs, analgesics, maybe an antibiotic ointment with those corneal abrasions as long as that penetration is not suspected. Adequate visual development does require appropriate sensory stimulation to both eyes. So when one or both eyes are deprived of the stimulation, then we have visual development problems and we don't progress, and that impairment or blindness can occur. Some common visual disorders include refractory errors, and these are our hyperopia, our farsighted disorders, or myopia, or nearsighted disorders. Astigmatism is that uneven curvature of the cornea, so unequal curvature of the eye treated with a special lens or laser surgery. And you can see pictured there that normal cornea and then almost that football-shaped eyelid or cornea with the astigmatism. Strabismus is that cross-eyed. So that's misaligned eye. The eye muscle has an imbalance. Successfully treated with vision therapy, corrective therapy should start relatively quickly. Amblyopia is poor vision in a structurally normal eye. The brain and the eye are just not working together. So sometimes you'll hear this as lazy eye. That eye muscle is very weak. So we will treat that with a patch or eye drops. Myopia is that nearsighted. We're going to treat that with prescriptive lenses. Nystagmus is that rapid irregular eye movement. So we know, again, if we don't see that red reflex in our newborn's eye, that could be an indication also of congenital cataracts that might be present. The other one that I do want to talk about is infant glaucoma and how it differs from adults. So infantile glaucoma is an autosomal recessive disorder. It's characterized by obstruction of aqueous humor flow and increased intraocular pressure. That results in a very large, prominent eye that leads to vision loss. Unlike adult glaucoma, in which medical management is that first step, infantile glaucoma is focused on that surgical intervention. Several surgeries may be needed for correction. The main goal of nursing care is post-op care and family education. Post-op care is going to focus on protection of that surgical site. Retinopathy of prematurity is a disorder characterized by rapid growth of retinal blood vessels in the premature infant. Risk factors can include low birth weight, early gestational age, sepsis, high light intensity, and hypothermia. Nursing management is going to focus on family compliance with follow-up recommendations. So there are some signs and symptoms of visual impairment, and it's generally going to differentiate between our infants and our toddler and older children. Visual impairment is just a general term that refers to visual loss that cannot be corrected without regular prescription lenses. So if you notice that your infant does not fix and follow, does not make eye contact, is unaffected by bright lights, or does not imitate facial expressions, that might be considered some visual impairment or visual loss, and we need to follow up with that. For our toddler and older children, if they're rubbing their eyes, they're shutting or covering their eyes, squinting, blinking frequently, sitting really close to the television, like bumping into objects all the time, or displaying a head tilt or forward thrust, those would be signs and symptoms of that toddler or older child for some type of visual impairment. So that concludes all the disorders we're going to talk about in relation to vision. So let's transition into disorders of the ears. Patients that are risk for infectious or inflammatory disorders of the ear can include eustachian tube dysfunction, recurrent upper respiratory infections, if they attend daycare or preschools, previous episodes of infectious or inflammatory disorders, or if there is smoking that goes on in the household. The three disorders that we're going to look at are acute otitis media with effusion, and otitis externa. So otitis media is a common illness in a child due to, again, that short length and horizontal position of that eustachian tube. Some of the complications of recurrent otitis media may include hearing loss, expressive speech delay. Remember, receptive is what they get first, expressive is what they can actually tell you. So you may see some delay in that. Tympanosclerosis and tympanic membrane perforation. Tympanosclerosis is that scarring of the tympanic membrane. Typically, there's no effect on hearing, but it may just be a complication of those recurrent ear infections. Viral causes of otitis usually resolve spontaneously, but bacterial causes may require treatment with an antibiotic. As far as nursing management, it's going to be mainly supportive in nature. It really focuses on pain management, family education, and prevention. When we think about managing pain, we may give our child analgesics, narcotics, or numbing drops. You can also apply heat or cool compresses for pain relief. We do want to educate our family on return to school precautions or return to primary care provider precautions. If there's no improvement in making sure that, we want to make sure that all those prescription medications are being taken. Some ear infections will just be monitored. If the pain is very mild and the patient is not having any fever, it could be viral in nature, and we may just monitor for more extensive symptoms. So the next one we're going to look at is otitis media with effusion. So that's that collection of fluid in that middle ear space with or without any infectious symptoms. So when we look at our otitis media with infusion, our OME, this refers again to that presence of fluid within that middle ear space. They may or may not have symptoms of an infection. Nursing assessment of the child with OME includes a really good health history, physical examination, and then some diagnostics. We will perform an otoscope exam, which may reveal a dull, opaque tympanic membrane that looks gray, white, or bluish in color. OME may take several months to resolve. Nursing management during this resolution phase focuses on education and monitoring for hearing loss. The standard treatment for persistent otitis media with infusion is our pressure equalizing tubes, our RPE tubes. These are those tubes that are surgically placed in the tympanic membrane via myringotomy, and these tubes will stay in place for several months, and they will generally fall out on their own. And then the last one we're going to talk about is otitis externa, and that's that inflammation of that outer or external ear canal. So otitis externa can also be known as swimmer's ear. And again, it's that infection or inflammation of that external ear canal. Its typical causes are from bacteria or fungal. Nursing assessment focuses on health history and physical examination. History will include that they've been swimming a lot, they were at the pool, they're at the lake. So a lot of times we're going to see this mostly in our summer months. Physical examination is going to reveal reddened ear, swollen, itchy, and it is very painful. The patients will have significant ear pain. Nursing management focuses on that pain relief and then treating that infection. When we think about hearing loss, this may be transient or permanent. It may be unilateral or bilateral. Language development is dependent upon our ability to hear. Hearing loss is measured in decibels, which is a unit of loudness measured at various frequency. So most of us hear at 0 to 20 decibels. That's normal. When we start having hearing loss, you're going to see those decibels go up because it has to be louder for us to be able to hear it. So you can see as it moves up, if you get to that greater than 80 decibels, that's very profound hearing loss. And that's when you may start seeing some hearing aids start happening. You may start seeing that even as low as the severe loss or the moderate loss. Some types of delayed onset hearing loss can be conductive, sensorineural, or mixed. So conductive hearing loss results when transmission of sound through that middle ear is disrupted. So we're going to see a lot of that otitis media with a fusion because that sound, that middle ear is being disrupted. That's that conductive hearing loss. When we think about sensorineural hearing loss, sorry guys, that's damage to the hair cells in the cochlear or along the auditory path. And then mixed could be attributed to both of those, a little bit of both of those. Once hearing loss is determined, then we can begin our interventions. Hearing aids, cochlear implants, maybe some communication devices, and also some speech education. Early communication just means that they're going to have better school achievements. So catching these early is vital. And that concludes chapter 39 on our disorders of eyes and ears. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.